Welcome everyone. Thank you. This has been an excellent session, and I'd like to congratulate all three presenters, Drs. Padron, Walter, and David Roman, for excellent talks. The session is now open for questions, and please do type your questions in Slido and we will read it out. And the first question, this is for Dr. Padron. Given the GM-CSF hypersensitivity as a pivotal axis of RAS pathway mutated CMML, what do you think about the differences in prognosis between JAK2 mutant CMML and RAS pathway mutant CMML, which is a principal biological distinction between these referred to in the axes?
It's a great question. So the way I view NRAS mutated and JAK2 mutated CMML is as follows. I think JAK2 mutated CMML is a very difficult entity to be confident in because of the overlap between CMML and classical MPNs like myelofibrosis. There's this common pathologic difficult question as to whether any given patient may have fibrosis with monocytosis and be called myelofibrosis or CMML. So, my suspicion is that JAK2 CMML many of them may actually behave like myelofibrosis, and that may explain differences in, RAS mutated versus JAK2 mutated disease.
Thank you.
Well, I have a question that follows up with Dr. Padron about also GM-CSF, but maybe more directly relevant to his really fascinating presentation that we hope represents a new therapeutic modality in CMML that, as you've shown, there really aren't any at the moment. So how much do you think the GM-CSF priming, if you want to kind of call it that, actually is responsible for the availability of the STAT5 to STAT3 switch? In other words, would IBET inhibitors cause the same switch in any type of leukemia, or does the GM-CSF background actually make the prime, if you want, prime it for the priming, or would you see the same switch in other diseases that aren't GM-CSF primed, like standard MDS or some AMLs?
Great question. So I think there is evidence in the literature in other cancers that STAT3 and 5 switch occurs with BET inhibition. So I would say it's probably a feature across subtypes of cancer. Regarding the priming, I think the way we're thinking about it is, PIM is a very unique kinase in that it doesn't need to be phosphorylated to get turned on, and it has a very short half-life. So as soon as PIM is up, it appears that leukemic cells become addicted to it. And so for us, the priming event is, do you have a sort of transcriptional program that is primed to express PIM, but is not doing so because of miR33A expression? That unique combination, and we're still working on identifying the subtype of leukemia that represents, but that unique combination really makes this combination therapy attractive. So having miR33A present, but also having a transcriptional program that does express PIM.
Thank you.
Eric, just a follow-up on the elegant work that you've done. Have you seen any genotypic correlates with response to BET-PIM in your in vivo models? Clinically, CMML is so heterogeneous. And so do you have any early signals, or is it one size fits all with BET-PIM inhibition, in your opinion?
It's definitely not one size fits all. I don't think we have the answer yet, but two things that we have found are, firstly, it looks like if you look at, for example, TCGA data in which there is microRNA sequencing, it appears that microRNA 33A is increased in RAS pathway AML. And so that may be a genotype. And it also appears to be the case that, while not a genetic marker, if you have cells that downregulate PIM, and that could be something that you measure, for example, in a clinical trial with, a few doses of BET inhibition. those cells are likely to be sensitive to the combination. So you can envision a clinical trial where there's a lead-in phase where you treat with a BET inhibitor, and then you measure PIM levels, and then you continue with combination therapy in those that actually get the desired effect.
Excellent, thank you.
Great. I have a question for Dr. Walter. The question was whether or not you can connect the allele-specific differences you've seen in splicing in cellular phenotypes with the allele-specific differences noted in RNA binding that was recently reported by Dr. Helin and their group in bioRxiv.
Yeah, the differences in the two alleles that we studied, the S34 and the Q157, they're known to have binding to different locations in the pre-mRNA at the +3, at the -3 and +1 position. And so each of these zinc knuckles are known to bind in these two locations. The splicing target differences are fairly canonical in the types of events that are misspliced by those two variant proteins. And they are sort of driven partially by the sequence context at those two positions. And so they have unique signatures, and the binding ability of these two different proteins to that sequence really underlies a lot of the differences that we see in them. The exact targets that are responsible for that, I think, are still going to be key, things that need to be studied functionally, and that we're just beginning to get a handle on that. And so I think that's the main difference is sort of their known biologic binding sites and the sequence context at which they change the splicing is predictive.
Thank you.
And Eric, there was a follow-up question to the JAK2 RAS pathway mutation. If I can just quickly share, we had looked at JAK2 versus, the RAS pathway mutant CMML a few years ago. And, what we saw was there's clearly an MPN phenotype in the JAK2 mutant CMMLs, higher hemoglobin levels, higher platelet counts, greater degree of reticulin fibrosis, more pronounced splenomegaly. But one thing that really helped us differentiate, JAK2 MPN versus JAK2 CMML was the monocyte repartitioning by flow cytometry. It has a very good specificity in picking up, the CMML phenotype with MO1 expansion vis-a-vis in the case of an MPN phenotype where you don't see it fairly consistently. And the follow-up question from one of the viewers is your thought on SH2B3, or what used to previously be called as LINK, a negative regulator JAK pathway. Any thoughts on that, Eric?
Well, in terms of their, in terms of the mutation rate, it's, to my knowledge, quite low in CMML. And so while RAS pathway is certainly enriched in this disease in terms of both mutations and downstream signaling, as Mrinal, you showed, I don't think that SH2B3 is commonly mutated. Now, could inhibitors of this be relevant in CMML? Absolutely, but not because of its direct mutation.
That's correct. When we did whole exome sequencing in the proliferative subtype, 90% are RAS pathway, 70% being conventional, NRAS, Sybil, PTPN11, NF1. And then the very uncommon drivers are SH2B3, CSF3R, FLT3. We saw 0 MIPL and CALR. So if you ever see MIPL and CALR with monocytosis, it's more likely MPN than CMML.
I have a question for Dr. Roman. He showed quite intriguingly that there didn't seem to be a difference in the overall survival of the dysplastic CMMLs that transformed to the proliferative CMMLs, at least if you look presumably from diagnosis. But nevertheless, there was a curve where he showed that the survival after the transformation, or if you want, or progression, was quite short. So that's a little bit of a paradox. And I'm wondering if you have enough patients to do kind of a matched pair analysis to pick patients who did not transform, but who lived an identical period of time, and then show that the ones that did transform lived shorter, or there's not enough patients. I'm just, when I looked at the data initially, I said, oh, that's interesting, but the two curves were not quite discordant. So I wonder if you wanted to comment on that, Dr. Roman?
It's true that in our base, the patients with CML proliferative, we don't have as much as the dysplastic. We have 41 proliferative versus more than 100 dysplastic. Maybe a reason of the bias might be there related to the N in our series.
Do you have enough to do a matched pair analysis to actually do, if you want kind of a landmark from when I could have but didn't versus when the other patient did, to actually show that there's a difference?
I'm sorry, I didn't understood. Sorry.
So I'm a non-statistician, so I can make up whatever I want. But the point is to show that the curve that you showed on the right, which indicated that the survival after transformation, if you want to call it, so the proliferative was quite short. But to actually show that that was shorter than it would have been if they had not transformed by doing a matched pair analysis to other patients with dysplastic who didn't. I don't know if you have enough patients to actually look at that, to actually make the point, if you want, in a non-randomized comparison, but at least a comparison.
I understand. Maybe we don't have enough patients at the moment.
Okay.
Dr. Roman, congratulations again. Great talk. I was very interested when you showed the Sybil and a few RAS pathway mutations in oligomonocytic CMML. Do you have data on their variant allele frequency burdens? And the reason I ask is because we had done a major ROC analysis, and we found that RAS-VAF greater than 20%, and especially for NRAS greater than 30%, clearly defines a proliferative phenotype. And so are these RAS mutations that you saw with low VAFs and early or subclonal, any insight into that?
Well, I'm not quite sure the VAFs that we found in the CBL for these patients. There are not many patients that have this mutation, but we could check out for the exact percentage that you're talking. But right now,
just a thought for the future. It would be nice to show that data, because my thought is that you will see either low VAFs or subclones rather than dominant clones, which we have shown correlate well with proliferative CMML.
Yes, I agree.
Thank you.
I have a question for Dr. Padron again about his very intriguing findings about PIM, which I must admit, when I first looked at, really caused me to scratch my head. So you said that because PIM is not it's more transcriptionally regulated rather than regulated by post-transcriptional modifications, post-translational modifications, that leads to easy addiction. Okay, I suppose it's just maybe a little bit counterintuitive that a malignancy that's already established and therefore has worked out its addictions, all of a sudden, if it gets another potential driver, why that should become addicted to. So I suppose I was going to ask a more specific methodological question. So in your paper, you actually picked clones that overexpressed PIM1 to show that you then generated sensitivity, but those clones have to be grown up. Have you done the experiment where you simply have inducible, where you can turn it on and then say, okay, how long does it take for PIM overexpression to really make the cells addicted? 5 minutes, 2 hours, 6 days, 10 weeks? And that would probably be relevant to the clinical situation, because as you showed from the BET1 inhibitors, the PIM1 gets turned on pretty quickly. So does that mean that, if you gave the PIM1 inhibitor with the BET simultaneously, you wouldn't expect to see anything at first? Like, how long would it take to establish the addiction at a cellular level? Maybe an unanswerable question, but a thought that crossed my mind when you said that.
Sure, no, it's a great question. So although we haven't generated like a dox-inducible PIM overexpressing line, what I can say is we've done time course analysis to see how long it takes for PIM to go up, at least by Western blot. And it's usually 16 hours. We can see it elevated and sustained on Western blot. In terms of the addiction, I think your point is well taken. And while it's probably not the case that under sort of native homeostatic conditions, as simply elevating PIM is going to addict the cell to it, I think in the unique context of BET inhibition that completely suppresses the transcriptome and specifically does so in inflammatory genes, that in that unique context that the cell is trying anything it can to start growing, that PIM addiction could occur. In our hands, if you generate BET persistent cells, for example, they grow far slower than their isogenic counterparts. So you're right. It's probably in the context of BET inhibition that phenomenon occurs.
Right. I mean, that's kind of what I thought, that there's something else that's happening downstream that basically is turning on another death signal that you didn't have before that PIM needs to counteract. And therefore, if you get rid of PIM, oops. But that's why I was really intrigued by just overexpressing PIM, making them addicted to it, because you haven't done that to BET. But anyway, I thought it was further, now you can have a fantastic second publication that follows up that answers that question.
Absolutely.
Okay.
Thank you.
Dr. Walter, I have a question for you. Again, great presentation. You mentioned the impact of the allele-specific hotspots. What about the impact of the variant allele frequency burden of the splicing mutations? Do you think they would impact how these modulators would behave once we get into clinical trials?
Yeah, it raises an interesting question of whether a fully transformed cell is actually dependent on the splicing factor mutation once you initiate a therapy or sort of impair splicing with one of these splicing modulators. I'm not sure that the tumor cells are still dependent on the splicing event. It is possible they are, but the approach has been, even if they're not dependent on the altered splicing for their maintenance, it could still be a vulnerability for the cell to be susceptible to a therapy. So for instance, if there's a specific splicing target that is present with the mutation and a splicing modulator further enhances that, you could then have lethality of the cell. So in that sense, the variant allele frequency will be important as a measure of tumor burden that contain the splicing factor mutant cells. I think if a cell is mutant and there is a vulnerability in that cell, that it would be susceptible to these therapies. So then it gets at the question of the order of mutation acquisition. We think that most of these splicing factor mutants occur early in disease pathogenesis, and then they're layered upon, make a cell maybe conducive to get other mutations, but it's not always the case. So there are certainly cases where these splicing factor mutants are in the subclone. And I think there it could be an issue if you have a therapy that is directed towards those cells. Of course, the subclones would be affected, but the founding clone would not be affected. So in that sense, the VAF of the mutation, I think, is important.
Excellent. Thank you so much.
I have another question for Dr. Walter, actually two about P53. One's very simple-minded, the other's probably stupid but convoluted. So the simple-minded question is, in your paper, when you actually looked at the cellular effects of enhancing inhibiting SMG1 that cause you increased R loops, you got lethality in K562, which I believe is P53 null functionally. Mm-hmm. So have you actually tried it in that particular context in patient samples who were P53 mutated and had the U2AF mutation that caused the, in other words, yes. have you found a P53 mutant effective medication potentially?
So we are actually testing that now. The U2OS cells have an intact P53 system, and they are sensitive in the same way, but we're expanding beyond the K562s because of that to specifically address the question. So don't know yet.
Okay, if I can ask my convoluted question. So most mutant P53s have the premature termination codon and therefore the onset mediated decay. So what would be the consequence in having a oligoallelic, or a low VAF burden P53 and then inhibiting that? Would that, other than enhancing R loop mutation, would that actually increase the number of transcripts of the abnormal P53 and therefore increase the ratio of P53 the wild type and therefore make them more like functionally biallelic rather than monoallelic? Or is that really just too simple an interpretation of what happens when you enhance R loop formation?
Mm-hmm. Yeah, essentially getting at, is there a risk or is there a benefit in a P53 mutant cell that you could sort of reactivate and make it appear wild type or functionally? I think it would have to do also with the translation of that. If you inhibit the NMD in a P53 transcript, would it be translated to still have a functional property in it? And again, something we hadn't thought about, but it's an interesting idea.
Excellent. Dr. Walter, one follow-up question. Are you worried about how the clinical trials are progressing agnostic to splicing mutations with their splicing inhibitors? Kind of, again, one size fits all, when you clearly show that although there's convergence downstream, there are differences in genes, hotspots, and disease types?
Yeah, I think for the first set of trials, I think we just have to gather the data and then see. But I think it's an important follow-up to look at this, because there could be, although there are shared similarities between them, there's going to be unique differences. And also gets at sort of looking in correlative studies at sort of broad splicing abnormalities, limiting it to a few sort of biomarker alternative spliced events. You could miss a signature that is specific to a given genotype. And although the splicing factor mutation patient samples are common in MDS, that's a benefit to be able to enroll a lot of people. The size of the trials still are on the small side. So figuring out some of these allele specific effects may be difficult, but something to keep in mind.
Eric, any anticipated toxicities if you go to clinical trials with combining BET inhibition with PIM inhibition?
Great question. So, for sure we're sensitive to that. We know, the history of BET inhibitors and their toxicities. And of course, there have been toxicities with PIM, especially when combining it with RUX, for example.
RUX, yeah.
The idea, though, would be, and again, it has to do, I think, with clinical trial design, is that perhaps we're not necessarily looking for an MTD. So I envision this lead-in phase where we would have increasing doses of BET inhibitor, but we're looking for the PIM upregulating dose rather than the maximal tolerated dose. And our hope is that that dose is far lower than the MTD, so that you get the effect of PIM upregulation, but hopefully not the toxicities. That just will have to see if that bears true in clinical trial.
So kind of a minimal effective dose rather than maximal tolerated dose. Yes, exactly. And that's the future for a lot of things, that we're going to be doing in this day and age. And I know that you found, the MER33 story is excellent, but have you also thought of looking into enhancers and transcription factors by motif analysis, given how, the BETs tend to regulate, especially at the promoters of the PIM kinase?
Yeah, one thing, and maybe we'll talk offline, is that, when we add the MER33A mimics, there is a partial rescue and not a full rescue. And we do have some evidence that there could be some transcriptional effects at play. That may be the differential effect of STAT3 and STAT5 on transcription of PIM, for example. But we're still working on that. That's definitely something that you and I can talk offline and discuss further. But you're right.
Well, I think I want to thank everyone for their excellent presentations and my co-hosts for fantastic juggling of the questions. I think we've had really interesting responses, and I'm grateful to the audience for submitting some also very thought-provoking questions. This has been an absolutely wonderful presentation. As I actually told the other presenters, because I was one of the co-hosts, I had a chance to see them before, and they actually get better on multiple viewing. And I know this will be viewable through repeat viewing. So I highly recommend you're seeing it again, because there's lots of really fascinating details that, unless you have a line that captures 10 gigabytes per second, will probably pass you by in all three fantastic presentations. So thank you to the presenters. Thank you to my co-host, and thank you to the audience. And please enjoy the rest of the symposium.
Thank you.
Thank you.
Thank you.